I would like to already start this panel discussion. So we can wait for the chair to join again. So thank you so much, speakers, for your excellent presentation. And we have a really interesting panel discussion with so many experts around the table. So that's really nice. I want to ask a first question to Prof. Yacit.
Yeah.
And like you shared during your presentation, malnutrition clearly robs children of their full potential with consequences for children, nations, and also the world at large. So although stunting has declined steadily since 2000, fast progress is needed to reach the 2030 targets. So can you share examples of countries that have recorded remarkable drops in stunting rates, best practice, and that other countries can follow as an example of success?
All right, thank you. That was an excellent question. Let me just share with you what we have so far now. Basically, when we talk about the countries that have more than 50% reduction, these are mainly coming from the upper middle income countries. But I won't go there for this question. Basically, I'm going to go back to the paper that was published in year 2020 in American Journal of Clinical Nutrition by Professor Zulfikar Bhutta and his team. Basically, he looked at, the team actually looked at qualitative and quantitative synthesis of data using a number of different ways, basically descriptive analysis of cross-sectional study, multivariable analysis of quantitative drivers, looking at the interviews and also focus group, and review of policy. And they actually, in that paper, describe that there are exemplar countries. These are Nepal, Ethiopia, Peru, Kyrgyz Republic, as well as Senegal. And what they have found in that paper, in that analysis that they did, is that these countries has taken a lot of initiative. And one of the most important initiatives is first, improvement in maternal education and maternal nutrition. I think this is very important. When you improve the girls, as I showed in my cycle of stunting, if the mother delivered a stunted child, delivered a malnourished child, the child will become a malnourished adolescent and become a malnourished young adult, and that leads to further problem of the next generation. So if you were to tackle, I think the most important is to look at the improvement in maternal education as well as maternal nutrition. Secondly, what these countries has actually done, what they have done is that they have improved in the maternal and newborn care. So that's another thing, because it's not just the education of the mother and the nutrition of the mother, but the care of the children are very important, especially during the perinatal, postnatal period, as again what Prof. Damayanti showed just now, importance of complementary feeding, and as I also share the importance of the dietary diversity during the complementary food process. And then the third thing that actually come out from this paper is the reduction in the fertility or increase the duration of inter-pregnancy intervals. That means you can actually give more attention to the previous child and improve the growth of the child before you get another child. So you see, a lot of things that needs to be done, and all these countries and their fourth important points that they brought out from that paper is that you need to have a proper roadmap to look at the diagnostics. Basically what, again, Prof. Damayanti showed just now, very important. You have to go to the ground and measure and really follow them up. You have to diagnose them early for you to do further actions to again prevent them to continue to have stunting. And we know you have to stop all these things from going on till the age of about 5, but there are some new papers, new studies to show us you can still help to improve their brain even at the age of 8 years, as I shared in my presentation. The next thing that they look at, other than the roadmap looking at diagnostic, is to make sure that you continue to consult your stakeholder. It's very important, all this consultation with stakeholder. And again, as what Dr. Ademi mentioned just now, if you do not have a good surveillance, you do not have a good, basically, coming back and see what you have been doing is good or not, you can't go very far, because you just cannot, you cannot see whether whatever that you have done has given you some improvement or not, right? So it's very important to consult the proper stakeholder. And the last thing that comes from the paper is that there need to be a direct and indirect nutrition interventions within the health sector as well the non-health sector. Basically, you have to involve everybody. It's not just a problem of Ministry of Health, it's a problem of the nation. So everyone has to come in, right? That's for me. Maybe some other people have their own thoughts. Yeah.
Excellent. Can everybody hear me now?
Yes, we do.
Yes.
Yes.
You're
Thank
back.
you, Francis. Francis was vice chair in my absence. Thank you very much.
So
Excellent.
I will leave it to you.
Well, I'm not sure you should, because I don't know what led to my computer stunting. So
Okay,
I
then
think
I will stay on.
you still
I'll stay on.
should still hang on. Thank you. So I was going to ask Professor Damayanti. Now there's a strategic movement that Professor Jalaluddin is advancing. That you must look at policy, you must look at the roadmap. And in your paper, you said that you should be doing growth monitoring. Now, how do you think Indonesia can actually adopt that growth monitoring approach so that it forms a critical part of the health response, the health system response to malnutrition? How do we do that in actionable terms?
Okay. Thank you for the question. Can you hear me?
Yes, I can.
Yes, okay. Actually, in Indonesia, since 1980s, the growth monitoring is already established through integrated community health center organized by village health worker. So every village in Indonesia, since 1980s, they have our system under the supervision of the midwife, village midwife, also the field nutritionist. Yeah. So if the child have weight altered, the parent will receive nutrition counseling from the nutritionist, but without looking for the etiology. That's the problem. Yeah. Since 2020, a new anthropometric regulation stated that every weight faltering child should be referred to the physician, because the cause of stunting not only because of reduced protein, but they also have a sickness. Yeah, so the physician should look of this patient. Yeah, the etiology and to do the prompt treatment. And also we have to revise the guideline for complementary feeding for children. So we said animal source protein should be provided locally available. So this one is signed by the Minister of Health. But unfortunately, when we want to implement this, the pandemic, there is a pandemic of COVID-19. So with the policy of the stay at home, and then we cannot close distancing here. So this is not yet implemented in the national level. But as you know, that I'm a lecturer, so I have already teach the pediatricians 10 years ago in the individual level. So every pediatrician, if you have the weight faltering, don't wait until they have mild malnutrition or stunting. Then you have to approach what should you do with that, and then we can prevent the stunting. So if you look at my study, in the one village, we use the pilot study. In 6 months, with this strategy, we can reduce 8.4% of stunting. Yeah, this is a simple one. They have already done it, but you can only, you only revise the referral. Yeah, and secondly, you have also have to refer the patient when they have malnourished. Not only stop in the nutritionist, but you have to send it to the physician to look for the possibility of the disease in this patient. So that's it, what we are doing in Indonesia.
Excellent. So it goes back to what Professor Jalaluddin was talking about, stakeholder engagements. So it's not just about the mothers or the children or the health workers at the primary care level, but the referral physician who also steps in at the end of checking if there is excessive utilization apart from inadequate nutrition. Excellent approach. Now, when you were presenting your paper, Professor Damayanti, you made it very clear that there are essential amino acids that are dietary sourced. They cannot be produced in the body. And that takes me to Professor Owolabi. Now, Professor Owolabi, Dr. Owolabi, you will realize that in terms of Nigeria, the country ranks as second in the world in the number of wasted and stunted children.
Mm-hmm.
And from the food consumption pattern, we realize that it's basically plant-based diets. And animal-based diets are better for proteins. And of course, eventually amino acids, essential amino acids. Now, there are studies that show that milk being one of the most dense in terms of nutrients can help to bridge the nutritional gap. So what do you think can be done in Nigeria to improve milk consumption among Nigeria children, seeing that currently the consumption level is still at about 12%? Professor Owolabi?
Yeah, thank you very much. The question I would say is philosophical.
Entirely not my fault.
Philosophical because of the level of poverty in Nigeria. Presently, over 70% are living below poverty line. And per capita milk consumption in Nigeria is just between 20 to 25 liters per capita per year. Meaning that in a month, we are just going to be consuming less than 2 liters, probably in the week about 500 meals. Per day, you can just guess that we are just about 75 mil of milk per day. And compare that with United States having about 267 liters per year, and United States does not fall within the first 5 countries that consume much of milk. I'm just trying to look at it how we could improve milk consumption with our poverty rate, and that's why I said is philosophical. And because based on that poverty, Nigerians majority see milk and dairy products as non-essential luxuries, and they would rather go for the staples: rice, beans, cereals, tubers, to provide the bulk of energy and fill tummy in their diet. So, but if we can truly improve milk consumption, we are directly going to be impacting on 2 of the SDGs straight: SDG 1 on poverty reduction and SDG 2 on zero hunger.
Yeah.
So how do we go about this?
That's a question.
That's basically the question. I think I need that background to help myself. 2 things come to mind straight to me. How we can do this. The first one, as just for us to to re-engage breastfeeding itself, based on WHO and UNICEF recommendation to go for 2 years, so we'll be able to take care of those age groups. But for this school age,
Yes.
we can incorporate the milk and milk product consumption into the school feeding program.
Absolutely. Excellent approach.
We could go incorporate it. Presently, for most of the menu for the school feeding program, on Friday, on paper, they are supposed to take biscuits and yogurts. On paper. So if we could integrate milk and milk products consumption into the school feeding program, this will go a long way to improve the consumption. And we said this will directly impact with SDG 1 and SDG 2. The other one is to look at issues regarding, if you say you subsidize milk consumption in terms of subsidize the price, we might eventually lose the benefit into middlemen that will eventually divert the product.
And the black market, true.
The black marketers.
Yeah.
So I was thinking about looking at something like a direct cash transfer in form of milk stamps, that there will be designated points within community that people of that age can go using a stamp that has been given to the poorest to approach the milk stand and get their milk products using the stamp that have been distributed to them. This, it might be a direct government intervention through this direct cash transfer that is going on to most vulnerable. The government is struggling to lift about 100 million Nigeria out of poverty. They are planning for 10 million for every year. So this might be a good strategy. In my place, they said if you can solve the problem of hunger, you have actually defeated poverty. So we can use this. We can use this food stamp approach to also be able to get even from children to cover even the school age children in improving the consumption of milk. And if the adult sees, they can visibly see the changes in nutritional status after this consumption by these children, then you can show the adults on their own will move in and begin to shift the mentality about looking at milk and milk products as a luxury item. Thank you very much.
Again, thank you very much, Dr. Wolabi. That key point that Professor Jalaluddin made about stakeholder engagement is still germane. So the government should start it. And when there is proof, the citizens will have a buy-in. An excellent way to look at it. Now, for Professor Marguan Sheng, I come over to you, sir. Now, among the predisposing factors for increasing prevalence of childhood obesity in China, fast food and physical inactivity are the first most important points. What can healthcare professionals in China do within their spheres of influence to change that nutritional narrative? And of course, other experts all over the world can adopt the same strategies, I imagine. Prof.
Thank you. Thank you, Doctor, for your wonderful question. As you just mentioned, the fast food consumption and also the lack of physical activity play an important role in the rapidly increasement of childhood obesity in China. Of course, there are, if we take a look back to 30 years ago, China also facing the double burden or triple burden, like the malnutrition, stunting, micronutrient deficiency. Of course, China still facing the similar problem like other countries. But in recent years, the obesity increased dramatically, especially in the past 30 years, not only among the adults, but also among the children, not only among the urban area, but also among the rural area. So obesity has now become a public health concern. Of course, we all know the causes for obesity is comprehensive factors. As you just mentioned, the energy dense energy dense food play also important role, and also other unhealthy eating behavior like skipping of breakfast, and also the consumption of sugar sweetened beverage, etc., etc. Regarding to the healthcare professionals, I think they can play a very important role in providing the counseling for the children, and also to guide the obese children to reduce their weight. Of course, to control and prevent of the childhood obesity in China, we need the whole system, the whole society to take action together, including the governmental agencies. Like I mentioned in my presentation, for the last the end of the last year, the sixth governmental agency released the implementation of plan of action for prevention and control of childhood obesity. And also the family, the parents play very important in the prevention and control of childhood obesity, because the lifestyle and the behavior the children will learn from their parents first. So the parents have a profound influence in fostering their behavior and their lifestyle. And also the school play an important role. In China, we don't have the education, the food education, the nutrition education. So this should be reinforced in China, and also all the community, including the food industry. They also need to provide more healthy food, and also to avoid the sugar free beverage to target the children. In conclusion, the control and prevention of childhood obesity needs the whole efforts of the whole society. That's my comments. Thank you.
Thank you very much. Thank you very much. And so Professor Ma has given us a strategy of bottom up and top down approach. Both must work together if we will combat childhood obesity and malnutrition indeed. I mean, Professor Olabi was talking about being philosophical. We know that it's been said that the child is the father of the man. So if you train this generation to eat healthy, then the next generation would have secured a buy-in. And I
Absolutely.
think that's a very pragmatic way of looking at it. Now, I've got another question for Professor Ma. This question says that there appears to be an emerging problem of concomitant obesity and stunting, in the same kind of population. I don't really fully understand what the question is, but it says there was a study conducted this year that found that 14.8% of newborns were victims of both stunting and being obese or overweight. So what are the contributing factors, and what strategies can be adopted to curb this going forward?
About 10 years ago, our team have analysis about the stunting obesity. That means for some children, when for some children, they have malnutrition before, like stunting, low weight, but when they grow up, they are likely to be obese when they grow up, and we call this a kind of stunted obesity. In China, we have found some of the children have this question. I think the measures is to treat to control and prevent of malnutrition and obesity together. Especially to treat the malnutrition in the rural area in China. That's still a task for us to make.
Yeah, I think that was a bit of a glitch there. Can you still hear me?
Yeah, yes.
All right, thank you for your answer. I was wondering if any of the panelists had further thoughts on that. Stunting and obesity. Yes, Professor
can I
Damayanti.
Yes, because I have already treated the patient with usually the patient who have malnutrition, undernutrition. They have also the mechanism adaptation from the body. They will reduce the fat metabolism. So if this malnutrition is chronic, yeah, and then what happened? The body is already has already think if there is food inside, and then they will oxidize the carbo and protein, but they will keep the fat. Yeah, and then that will happen if you see that your child is become wasting, and then the doctor of the nutritionist will give food. Yeah, the normal food they give will be stored as a fat. That's why what we call it the early adiposity rebound. If you give food, especially for the child who is IUGR, usually we want to we will give a lot of food to this child, yeah, to this baby, and then we forget to monitor if the growth is already enough or not. And the child will be have a fat in the body, and then this fat will be growing to be the syndrome metabolic in the next adult. So this is what is the problem. Actually, the problem if the child obesity is they will become a problem in the future. Sometimes now it's not in the future, because in the young child I have already got the syndrome metabolic, although the definition is after 6 years. Yeah, but before then I have already find the babies and the young child with all the dyslipidemia, the high glucose tolerance, and something like that. So this is the what is the cause? What is the correlation between the undernutrition and overnutrition? Maybe that's what I can explain to you.
Can I add a little bit on that?
Yes,
I think when it comes to obesity and stunting, we need to look at the type of food that the child is that is available to the child, right? A lot of times when it comes to economic issue, as I think we heard a few times earlier, protein is usually much more expensive. Because of that, you would go for less expensive food, but with higher calorie. That comes from a lot of carbo. Then if you were to take that a lot, excessive carbo definitely will give you fat. You may not get that much height. And because of that, you may develop into having problem with overweight, obesity, but stunting. I think from the point of view of an endocrine person, when it comes to growth of children, if you don't have enough protein, you don't get the height. If you don't get enough calcium, vitamin D, phosphate, and all that, you don't get enough height as well, because your bone just does not have all the building blocks for you to grow. And then because of that, if most of the nutrient that these children get are carbo or very low dietary diversity, they will end up keeping in all the fat and not getting the height. So I think that's another point that we have to look at when it comes to reintroducing the food to this group of children. Yeah. And like Prof. Damayanti mentioned just now, if you see children who has SGA, you will only want to bring them in and keep them within the 25th to the 75th percentile. You don't even want to allow them to go beyond the 75th percentile, because that will push them into the problem of overweight, obesity, not very long from where they are. See, you do not need to wait until they are adolescent or even young adulthood. They can already go there when they're around 5 years old. Okay.
Thank you very much. Can you hear me, please?
Yes.
Yeah.
Oh, thank you. I was having some technical glitches, but hopefully I should be fine. The other question that I've got here is that in the presentation by, I think, Professor Ma, there was the use of 8 food groups, or maybe it was Professor Jalaluddin. I can't be too certain, but the participant is interested in this. In your presentation, you indicated the use of 8 food groups for the dietary diversity score, while others use 12 or 16. What is the ideal number, and doesn't that lead to a difficulty in comparison?
Okay, I think if you were to look at from the point of nutritionists and under the UNICEF as well as WHO, your current food groups are only into 8. Previously it was just 6, then 7, and now 8, because it separated the breast milk from the whole from milk. So that's why the food groups become 8 now. So if you look at dietary diversity, you need to have a minimum of 5 to tell you that you have a good dietary diversity. Yeah. So I think internationally accepted that 8 food groups is the one that you're looking for. I'm not sure where this 12 and 16 actually comes from, but if we were to look at under the nutritionist point of view, when it comes to food groups, the most current food groups that they actually put into is actually 8, not 6 or not 7 anymore. Yeah.
Excellent. So a good score or figure is 8 for food nutrient diversity or food diversity.
You have to have at least 5 out of 8 to consider that you have a good
at least 5.
Yeah.
Oh, great. So I think it's a learning point which we all can take from here. There is another question that's linked to the age of vulnerability. So the question is, now that we know that the period of catch-up growth can exceed 5 years, is it advisable in public health intervention to extend the age of vulnerability therefore beyond 5 years, or we should keep it to 5 years and be more aggressive within those 5 years rather than to relax?
Okay. I'm going to approach this into 2 different ways. One, now we talk about a lot in terms of 1,000 days of life. Then there are new movements to show to us that you should not neglect the one between 2 to 5 years, because between 2 to 5 years is still vulnerable. You can still bring them out from that issues that they have. What I'm trying to show in my presentation is that we should not just stop at 5. Okay, if we are not successful in terms of bringing them back into the normal curve, in terms of their height, in terms of their weight, we should not just stop there. We should continue to do the best that we can, and why? Because studies have shown that their brain function, their cognitive ability, their behavioral, because of the development of the brain that continue to develop even beyond 5 years, we can still save part of it. So we should not just stop at 5, but if you ask me, should we change the policy to push to 8? Then if you do that, people may be complacent. People may not do the people may not put the whole kind of like effort to make sure within the first 5 years you need to do everything during that period of time. But if you cannot do it by 5, you still have some time to carry that work that you are doing. Hopefully, that will improve these children. That's my take on it. Yeah.
Thank you very much, Professor Jalaluddin. To our panelists and the participants, we have just about 5 minutes to the end of today's conference. I wouldn't mind if we could have any parting shots from any of the panelists over the next 2 minutes, and then that gives me 3 minutes to close. Thank you very much.
Yes, I would like, can I give the, hello?
Yes, please. Please
yes, can I give, yes, I would like to comment about your question about the brain development. Is 80% brain development is in 2 years old, until the child is 2 years old. This is the biggest part of the brain development. That's why we discuss about the 1,000 days of life, because actually in the pregnancy is only 25%, but another big part is in 2 years. But the brain is still growing until 5 years. It's 90% from the adult, and then also until 10%, about until 10 years, about 100%. But if you know, that's the synapse. It's still growing until the child 18 years, until we are now. The synapse is still growing. So the synapse need more food, more the complete food, not only one part of food, but the complete food. That's why we have eating until we old, But the very important thing who make the human resource for one country is the first 2 years, the first 1,000 days. So if the child is already born, it is 2 years, because 80% is there. Neuroplasticity is there. If the child have a problem, so they can grow another part in these 2 years. But after that, it's very difficult. It's something like that. Maybe people should understand about that. That's why the nutrition, it should be needed until we are old, like now. Yeah.
Thank you very much.
Yeah, thank you, Prof. Damayanti. Yes, I think that made clear to. I think you have made it very clear. Is that the first 1,000 days where the brain development is the most? That's where you want to aim for. But if you can't, you still have the time to do something. But it's not as good as if you were not to be able to do it in the first 2 years of life. Yeah.
Thank you. Thank you very much. And I will tell you that as a psychiatrist, 50% of mental health problems are found in children and adolescents, 50%. So the earlier we intervene, the better, so that it doesn't become a little too late. Too little, too late. Let me put it that way. Distinguished ladies and gentlemen, once again, I'd like to thank our panelists for a very warm and engaging session. Indeed, today's focus has been on healthy nutrition for health improvement in early life. The key findings that we have found today have been in terms of malnutrition and the global challenge that it constitutes. We have also had the privilege of listening to the many regional initiatives that have been taken to combat malnutrition. And on that note, I'd like to say that we have had a most enriching session. Please, participants, before you go, would like to encourage you to remember to share your opinions as you fill our evaluation forms. The presentations for today will be available on demand till the end of the day. The report of the conference and videos will be available on FrieslandCampina Institute website as from the 29th of June, 2021. And you will have a link to download your digital briefcase as from next week. A link to download your attendance certificate will also be available from next week. On behalf of FrieslandCampina Institute, I would like to thank you very much for joining in our first global virtual conference. And I dare say that it was a huge success because of your participation. We indeed look forward to seeing you in the future events. On that note, as chair and moderator of this panel, I'd like to wish you all a very pleasant rest of the day. Thank you very much.
Thank you.
Thank you. Thank you.
Bye-bye.
Bye.
Bye.
Thank you very much. Bye-bye.